So I'd like to introduce our guest speaker for today. Claire Ludwig is a PhD candidate in the School of Nursing at the University of Ottawa. Her doctoral work is focused on patient engagement and research, specifically engaging frail and or seriously ill patients as knowledge users. Her other research interests examine how patients and nurses negotiate the process of triage and self-management in cancer symptom management. Claire is a senior healthcare leader involved in the development, implementation, and evaluation of large-scale programs aimed at improving patient and caregiver outcomes. She's also a patient with cancer currently receiving immunotherapy treatment, and she's served as a knowledge user on research projects as a healthcare administrator and as a patient advisor in the acute treatment phase of her illness. So I'm going to hand it over to Claire, and she'll tell you a little bit more.
Thank you. Thank you for the introduction, Dawn. And thank you, everyone online who are taking time out of your busy day to join me for my presentation today on engaging frail and seriously ill patients in research. And this certainly is a topic that is front and center for me. So we can't start a presentation on patient engagement in research without a patient story. And the story that I will tell you today is actually my own story. And it essentially has three parts and speaks to my personal experience with integrated knowledge translation research, but also speaks to my own personal experience. So you might find that my voice gets wobbly in part, or my word searching result of chemo is sometimes a little bit slow, so please bear with me. So the first part of my story, or chapter 1, if you like, is about my initial exposure to integrated knowledge translation, and that was as a senior healthcare administrator. I was actually a knowledge user on one of Dawn Stacey's research projects, looking at implementing cancer symptom management guides in the home care setting. And although I'd been involved in research projects previously in my capacity as a healthcare administrator, I was really struck by the difference in this approach to research. It wasn't the first time I'd been involved, as I said, but it was the first time where it wasn't just a request for data or for study participants or for an interview about my experiences as an administrator. But this was a time where everyone came around the table, researchers, administrators, managers, nurses, even a caregiver. Imagine that, engaging the very people that would be impacted by the research. It was a very different level of engagement and really a different way of doing research. And I was so enamored with this approach that I was inspired to pursue a PhD. And that's where chapter 2 of my story begins, in my role as a PhD student and a research assistant on another IKT initiative. And life at that time was really very good. I had these 2 roles that I'd chosen. They were serving me well, and I embraced my new life in academic studies really wholeheartedly. But unfortunately, this chapter is a relatively short chapter because months into my PhD, I moved very swiftly into my next role. And it's the third role, the third chapter of my story or of my life that has had the most profound impact on my views of patient engagement in research. And I call this the role that picked me. About a year and a half ago, after several months of feeling unwell and after actually 4 courses of antibiotics for pneumonia, I became acutely ill. So ill that I was admitted to the hospital as soon as I showed up at the emergency room. The 11 days that I spent in the hospital are pretty much a blur to me now, but during that time I was diagnosed with advanced non-Hodgkin's lymphoma. I was, and indeed now am, a patient with cancer. In fact, I will remain a patient with cancer for the rest of my life. My cancer is incurable. By the time I was diagnosed, I had significant tumor burden throughout my body, as well as having over 50% of my bone marrow infiltrated by cancer. On the prognostic indicator index, I had 4 out of 5 significant risk factors. I am at high risk for a shorter and a poorer outcome. And let's be clear, I'm not imminently dying, but I do know that my life is significantly shortened. It's a reason I've stopped paying into my retirement savings. I'm in remission now, remission of sorts, but I do have regular immunotherapy treatment to keep me in remission longer. Statistically, I'll be in remission for a few years before my disease raises its ugly head again, far enough away, but not nearly long enough. And it's this experience that has shaped and reshaped my thoughts about patient engagement in research, and I'll come back to that part of the story at the end of the presentation. But for now, what I want to do is to look at what the presentation will involve today. So we're talking about engaging patients in research as knowledge users. And let's be clear, when I'm talking about this, it's about doing research with patients or research that is done by patients. It's not about doing research for or to or about patients. I'll also speak to notions of meaningful engagement and the benefits and pitfalls of engaging frail and seriously ill patients. And then, as I said, I'll come full circle back to my own story. So, patient engagement, there are actually a plethora of definitions, but in the Canadian context, CIHR defines patient engagement as the governance, priority setting, and conduct of research, and/or summarizing, distributing, sharing, and applying knowledge. And in the Canadian context, as there is elsewhere, there's a focus on making research more accountable and more transparent, as well as an acknowledgement that through involving patients in the design of studies, it leads to better outcomes. In the US context, PCORI, or the Patient-Centered Outcomes Research Institute, defines engagement as meaningful involvement throughout the research process so that research is patient-centered and useful, and thus more likely to be used. But the level and depth of engagement is also something that occurs within patient engagement. There's a matrix, so there's stages along the research continuum, but there's also the level involvement, i.e. the depth of engagement and the influence that stakeholders have in the decisions that are ultimately made. And this happens along a continuum. So we have influence running from a relatively low level of influence and involvement, so informing or listening to patients or gathering information from them, moving through to discussion and consultation, and then moving through to the higher levels of engagement and influence at the other end of the spectrum, with the highest level being partnership. And ideally, where we want to be is at that further end in terms of engaging and partnership. The level and depth of engagement is particularly important when we think of meaningful engagement. We know that patients from ethnic minorities or from marginalized groups remain underrepresented in patient engagement studies, and that's even more so when patients are seriously ill or are frail. So we need to make sure that our recruitment strategies for our knowledge users are both targeted but also flexible. We need to think about the hierarchy that exists in our research environment and how certain bodies of knowledge are privileged over, say, experiential knowledge. And we need to ensure that we're creating these safe participatory spaces for our patients to feel included and to feel that it's collaborative and interactive. And we know that this is particularly important in the biomedical research space because it has been a traditionally closed space. So why engage patients? Looking at this exploratory study that was done in the UK, it was actually the first consultation to be conducted with UK patients, UK cancer patients about their research priorities. And there was a mismatch, quite a mismatch. Patients' highest ranked concerns were not being addressed by the National Cancer Research Program. Patients' concerns were typically, or priorities were concerned with the impact that cancer has on their life, how to live with cancer and related support issues, essentially their lived experience of cancer. But patients were also interested in risk factors and the causes of cancer, as well as early detection and prevention. The National Research Program was really focused on treatment and biomarkers. So you can see that with patients' voice in there, that those priorities might look quite different. And we know that setting research priorities that incorporate the views not only of healthcare providers, but of patients and caregivers can improve the relevance, quality, and uptake of research. But this approach is not typical. The James Lind Alliance is an international leader in setting research priorities, and the Alliance recommends bringing patients, caregivers, and clinicians together along with representative organizations to reach consensus on the top research priority. And it's really not a question of whose priorities are right, but it's really about how patients and caregivers and researchers come together to reach a consensus so the end results are of more benefit to the end user. In a 2017 Canadian study, there was a collaborative consensus-based priority setting partnership that identified 10 research priorities in the management of kidney cancer. And it was really a collaboration between the Kidney Cancer Research Network, the James Lind Alliance, Kidney Cancer Canada, and the Kidney Foundation of Canada. And the James Lind Alliance technique was adopted to define the following top 10 priorities that you'll see here. Actually, there was a three-way tie for the top three. And interestingly enough, you'll see that patient priorities around supportive care needs and decision-making tools fit within that top 10. So there appears to be a benefit of engaging patients in research, but can patients be engaged easily? So Demek and colleagues conducted a systematic review back in 2014, and their findings across 142 studies suggest that it is feasible in most settings. And typically it's done at the beginning of the research continuum, agenda setting, applying for funding, and in protocol develop, and occurs less often throughout the research continuum, certainly in terms of executing research, data collection, data analysis, and there is some evidence of involvement in dissemination activities. So the benefits that were noted in that review were that it did increase study enrollment rates and aided researchers in securing funding, which is always a benefit. But there were challenges such as extra time and extra funding required. And there was also this overarching worry of tokenistic engagement, and I'll come back to that later. So we've looked at the ways in which patients as more of a collective group are engaged in research, but now I want to turn your attention to engaging frail and seriously ill patients as knowledge users. And really my own illness experience has shaped my research interest in this area. And this topic was actually sparked during meetings with my PhD supervisor, Dawn Stacey, and my comprehensive exam committee. And those meetings were occurring at the time when I was in the acute phase of my illness and treatment. It was actually discussions that occurred during my chemotherapy, particularly difficult time in my life. But on the upside, I guess if you can call it that, the upside was that I was set a question, and essentially what you see here is that question. So the aim was for me to conduct a review of studies in which frail and seriously ill patients were reported as being engaged as knowledge users in research. Obviously, before I could tackle the literature, the terms needed defining, and you can see the terms here. So frailty is typically seen as a geriatric condition involving functional decline, and certainly there's increasing vulnerability to adverse events, premature institutionalization in nursing homes, hospitalization, morbidity, and disability, and/or the presence of multiple chronic conditions such as arthritis, heart failure, and/or the presence of cognitive decline and dementia. In terms of serious illness is defined as a high risk of mortality, negatively impacting the quality of life and daily function, and/or is burdensome in terms of symptoms and treatments. And certainly my own non-Hodgkin's lymphoma is an example of that, but other cancers as well as advanced liver disease, advanced pulmonary diseases, and advanced heart disease. And so I worked on the PICO framework, and obviously the population I was looking at was frail and seriously ill adult patients. The phenomenon of interest was patient engagement in research, and really I was looking at the outcomes and methods and timing of recruitment, practical issues, and the impacts of engagement. And I was looking at any study reporting on patient engagement, and articles that were published in English. And so I worked to come up with a very comprehensive search strategy, and the following databases were searched. And narrative synthesis was around recruitment methods and the levels of engagement, the practical issues of engaging frail or seriously ill patients, and the perceived benefits or impacts for patients, researchers, and the research itself, as well as the ethical issues of engaging frail or seriously ill patients. So in terms of the results, out of 635 titles and abstracts or retrieved citations, there were only 18 studies that met the inclusion criteria. And in synthesizing that, as I said, I used the framework for synthesis, and so the strategies and methods of engagement. In general, most of the articles describe convenience or purposive sampling as the method to identify patients for engagement in research, really where patients were readily available. Patients were recruited in some studies by their own healthcare professionals, providers, or from sites where the healthcare providers had ready access to cancer clinics or other outpatient clinics, day hospice or inpatient hospice, and others were recruited through survivor groups, particularly in terms of cancer research. And in the US and the UK context, where patient engagement or involvement is further ahead and there's a more established infrastructure for engaging patients, advisory groups were used, advisory groups like stroke, dementia, and Parkinson's groups. And there are also increasing efforts underway to recruit patients from primary care. So there were, however, although the articles reference recruitment of frail and seriously ill patients, there was a paucity of detail about how the patients were recruited. Were they interviewed? How were they brought on to the research team? And I think this continues to beg the question about, you know, is there a process and what should it look like? Engagement also seemed to focus on early engagement. So, you know, in line with the review conducted by DMEC in terms of finding frail or seriously ill patients helping in research, they were typically focused on early engagement, finding study participants or keeping study participants, or, you know, setting the research question, as we've seen, in terms of research priorities, mesothelioma, and in terms of the conduct of research and the dissemination of research, there really is limited evidence. You'll see there's a study there in terms of having the elderly involved in data collection. So a Dutch study where the elderly were actually interviewing frail elderly people in the community to collect data, and those interviews actually elicited more candid responses from people, so of great benefit. But there are a number of practical considerations for patients who are frail and debilitated. And although these are similar to the general population of different patient groups, additional consideration is required for patients who are frail or ill. Thought has to be given to how patients can best contribute to discussion. Patients who are short of breath, for instance, can't travel for long distances, walking to meeting rooms. So in-person meetings may not be appropriate for some groups. And then thought also has to be given to those with compromised immune status, particularly following chemo or stem cell transplant. Exposure to common viruses can be potentially deadly to those patients. And teleconference and video conferencing may seem like great options, but attention needs to be paid to vocal capacity. So studies showed that where patients had throat cancer or Parkinson's disease, they may have great difficulty communicating via phone. And certainly telephone communication for patients with mild cognitive deficit or dementia is very difficult. And obviously, there's also a barrier to enabling contribution around the medical and academic jargon that's used. So time is precious for everyone, and certainly, you know, we need to be as efficient as we possibly can be, but time assumes a greater level of gravity for patients who are coping with life-limiting illness. Every moment counts, and I think that we need to be particularly respectful of this, as well as continuity of contribution. And that's a major consideration, certainly when engaging palliative patients in research or patients with other debilitating illnesses. What happens when your patient has a condition that deteriorates or the patient dies? And there's really scant reference in the literature to what about the emotional considerations of engaging with patients who die, you know, what kind of support is there for your team who may be going through a grieving process? How is the team supported through this? So, and there are obviously practical considerations as well for expenses, you know, perhaps additional costs for patients who are traveling, who may be traveling to meetings nationally, who may be too frail to travel in one day. So those kind of things have been found to require attention. Role clarity is a big issue that comes up in the literature, and I think that's incredibly important as well when we think of meaningful patient engagement. And it's really important that expectations be established up front so that both the patient and the rest of the team knows what their role is. And the literature also spoke about how teams need to consider how roles might evolve with patients who become sick. There needs to be flexibility if the patient becomes too unwell to contribute in one way. Maybe there's another role that they can play. Do they become ad hoc advisors? Do different patients become engaged for different parts of the study? These are things that teams have had to think about when engaging this population. And creating a safe team environment is very important, as is the recognition that there are equal voices in the room, but those voices play different roles perhaps in shaping the final outcomes. So in spite of all of the considerations, there are a number of perceived benefits, particularly for patients, and the literature has spoken to the transformational function that can happen with patients who are engaged in research, the acquisition of new skills and knowledge, and this protective factor against loneliness or isolation is particularly prevalent in the literature with the elderly and with certain cancer groups. And there's this increased sense of agency again, that reconstitution of self, the reduced sense of hopelessness, and the emotional support that is gained through contact with the team. And other studies have described, you know, patients having increased knowledge of their condition or the available treatment options, the new treatments coming in. In terms of the researchers, there's an increased knowledge of lived experience of the disease that they're dealing with, and there's also access to that experiential knowledge that isn't gained through textbooks. But interestingly enough, less appears to be known about the perceived benefits for researchers themselves. And it's kind of ironic because most of the accounts of patient engagement are actually provided by researchers, yet there seems to be a shyness or a reluctance to speak about their own experience in the process. For research, I think I've spoken to some of that earlier in the presentation, but I want to really point out that certainly in some of the studies, the fact that there's a human face to end users has been particularly important in dissemination activities or raising awareness of certain research initiatives, particularly in the clinical trials study. And obviously we know if there is this human face, hopefully we would have an increased uptake in the research findings. So in terms of the ethical component of the paper, I use the Tri-Council policy statement, the ethical conduct for research involving humans. Everyone on the line will be familiar with that. And it outlines the ethical norms to guide researchers in the conduct of research involving humans. But although it governs research on humans, it also provides a suitable framework to examine the ethical issues of engaging frail and seriously ill patients in research. And it has 3 core principles: respect for persons, concern for welfare, and justice. And I use those principles to synthesize the findings in the literature review. So respect for person really encompasses autonomy and consent, and relational power can be very subtle in a team dynamic, but it can also be more overt. And there's been some increasing critique in the ethics literature about the ethics of physicians recruiting their own patients for engagement in research projects. Control of information is another particularly sensitive topic. How much information is disclosed in research meetings, and I think that this explains some of the lag in patient engagement activities for some of the clinical research trials, because there's an obvious tension there about the possibilities of physicians disclosing early results that may in fact be disappointing to patients on the research teams. Consent as well, particularly with a frail and seriously ill population, is of grave concern or has received a lot of attention in the literature, because consent is fluctuating in these populations, not only when we think of dementia or cognitive deficit, but also aggressive treatment regimes can impact a patient's ability to provide informed consent temporarily. So consent really does need to be addressed and reassessed at each point of contact with the patients on your team. There's that assessment that takes place there. And there's also this kind of dualism, this subtlety of the patient who is participating on the research team, who then becomes the object of study as we build the knowledge base around engaging patients as partners in research. Some studies in the review, particularly those studies that looked at engaging palliative and cancer patients, described how patients on the team experienced a sense of vicarious trauma in reliving painful experiences or being exposed to information on what might lay ahead for them. And I'll come back to my own experience here. From my experience reading some of the accounts of patients in the literature, I remember feeling very overwhelmed at times, becoming quite tearful, sort of reliving my own experience and seeing again what might lie ahead. So there are points where patients may need to step away in terms of ensuring that their welfare is protected. And the sheer emotional and physical effort required for some patients to participate needs to be considered on an ongoing basis. And like consent, this fluctuates. 1 week you might find one of the patients on the research team is doing very well, and then post-treatment not so well. And these studies also highlighted the issue of confidentiality and control of information. There's a great vulnerability for many patients disclosing illness. There's still a tremendous amount of stigma associated with some diseases or some conditions, and patients are really putting themselves out there in the public realm, and I think researchers ethically need to be aware of that, and that has been highlighted in a number of different studies. The final principle of justice really is around fairness and equity and inclusion, the right to inclusion. And really, as we know, patient engagement has been described as a moral and an ethical imperative. But researchers also need to be aware of the subtle and not so evident relational power differences. Patients in the unfamiliar world of research, hearing unfamiliar terminology, who are also coping with a loss of self-esteem or maybe a reduced sense of agency, can be really vulnerable in an inequitable power situations. And the studies highlighted the need for contributions of patients. The contributions need to be valued or at least acknowledged. And as clinicians and researchers, there's an awareness of gatekeeping and how some patients are selected out of participation because we may fear that they're too sick or too unwell or too frail, but they have the right to inclusion, and it's really about an informed right to participation. So in summary, there is an underrepresentation of frail and seriously ill patients in the literature, and where they are included, there's really very few studies that provide detailed evidence, and particularly detailed evidence of patient characteristics. And it's hard to know, is this, word count for publications? Is this to do with ethical issues around protecting patients' confidentiality? But this is an area, I think, that needs more investigation. And we really need to outweigh the benefits of participation with the costs, and patients need to be providing a voice into that input. And obviously, we need to balance the rights to involvement with the benefits to efficacy and the impact of patients' participation. So all of this, I think, makes us think about, is patient engagement about ticking a funding box? Is it about, perceived to be doing the right thing, or are we serious about meaningfully engaging patients? So this is a question that I'm sort of posing, I guess, out loud in terms of, if you're considering or you're engaging patients already, are you thinking about how you're creating those safe and collaborative spaces? Are you thinking about honoring patients' contributions in a realistic manner and the flexibility that's involved, particularly around not only engaging frail and seriously ill patients, but patients with other illnesses, and the costs? It costs more. It's ironic because patient engagement helps to secure funding, but it comes at a cost. So I think we need to be aware of the costs of doing that, and particularly when we're engaging more vulnerable populations that require more time, more flexibility, and more resources. And do patients know what's in it for them? And as a research community, do we really understand what's in it for us? And in terms of expectations, there's a real dissonance between patient and researcher expectations. Patients with life-limiting illness or those living with debilitating conditions obviously want to see results quickly. Researchers, on the other hand, have more experience about the pace at which research moves, typically in smaller incremental steps. And so now I want to come full circle and speak to my own experience as a patient engaged in a research team. My illness wrought havoc on my self-esteem and my confidence. I was knocked for six, I guess I could say. I had had a successful professional and academic career. I was doing really well. I was never shy to speak up, never shy to question, but coping with cancer and the various treatments along the way have shaken me in a way that I never thought possible. And certainly in those early days post-diagnosis, I struggled to find purpose and meaning to it all. And sort of halfway through my chemotherapy treatments, I was at a particularly low point, and I actually reached out to my PhD supervisor, sitting beside me here, who was and actually still is an amazing support to me throughout this journey. But I reached out to Dawn to volunteer my help on a couple of studies she was working on. Not as a patient initially, but soon I couldn't extricate my own experience as a patient. It was working on cancer symptom management practice guidelines, listening to symptom management calls received by nurses and helping patients triage and manage their symptoms. And it was at the same time as I was struggling with those very same symptoms, and I realized very quickly that my analysis wasn't in my academic headspace, but I was really analyzing those calls through a patient's lens. And so it's been a really strange shift in terms of being engaged as a patient. My energy levels have meant that my participation has been sporadic. My attendance and presentation at a conference had to be aborted because of neutropenia and a nasty infection. And I've been incredibly vulnerable at times, even today, talking about my own experience. Talking about illness is a tremendous risk, particularly talking about a life-limiting illness. It opens me up to judgment, I feel, to stigma in some circles, and can be potentially career limiting. Who wants to employ somebody who has a shortened life? And I've been exposed to things on a research, as a patient on a research team, that I think I've actually been sheltered from as a PhD student. There's a gravity to how I perceive things now as a patient. An oversight on authorship to a paper or an angry email might be part of a regular workday, or a lapse in judgment or lapse in memory, but it takes me to a whole new level of distress as I question whether my input is sufficient or good enough. Yet on the upside, most of this experience as a patient engaged on research teams has allowed me to rebuild myself, reconstitute my sense of self, my sense of agency, particularly over a disease over which I have very little control. And so as researchers, I think we hold lots of assumptions about what constitutes a typical patient, about the knowledge they hold. Some of us may even question whether their knowledge is legitimate or whether it is useful or valuable. And we might question why patients are overly emotional or find it difficult to move away from their own personal story. But patients don't constitute a monolithic culture exclusive from us. Our patients are very much like ourselves. And I want to end this webinar today with a quote. Illness is the dark side of life, a more onerous citizenship. Everyone who is born holds dual citizenship, in the kingdom of the well and in the kingdom of the sick. And although we all prefer to use the good passport, sooner or later, each of us is obliged, at least for a spell, to identify ourselves as citizens of that other place. And that's where I want to end my presentation today. Thank you.
Thank you very much, Claire, for a very enlightening presentation and helping push our boundaries around how we think about patient involvement as part of our research teams, our conference planning teams. There's many different ways in which we're now trying to make sure that we are involving patients in what we do as researchers. I'd like to open it up to questions, and I am following the chat box if anyone wants to put their questions in, but I'll open it up for questions. So, Western Canada.
Sorry, Dawn. Everyone is muted, so they know to use the chat box. If they have a question, we kind of had to go that route because of all the trouble we were having with background noise.
Okay.
Yeah, so they'll come in via the chat box.
Thank you, Megan.
No problem.
I think what I'll do is I'll start with a question that I often struggle with as a researcher, and that's around what is meaningful. Like, because in the documents from CIHR and PCORI, and when we talk about patient involvement in research, it needs to be meaningful. And so, Claire, can you talk a little bit more around, like, how do we measure that? How would I know if I've managed to achieve meaningful engagement?
Well, I think it's, you know, meaningful engagement is a really interesting concept because on the one end, you have this very sort of nebulous theoretical concept of what it is in terms of meaningful engagement, like creation of safe participatory spaces. And then on the other end, you have very concrete recommendations. So things like patients must be compensated for costs, must be shown what their impact has been, consideration must be given for, you know, various states of health, but I think we don't have a clear understanding of it. I really believe that, you know, we need to land somewhere in the middle there, and I don't think that we have enough of the voice of the patient in that. We have, in the literature, when you look at patient engagement, it's either sort of concepts or values that people have come up with, or very concrete steps, and somewhere in that, the voice of the patient needs to be measured more effectively. And we know that there's a lack of qualitative studies in terms of looking at integrated knowledge translation or the patient experience in being engaged in research. So I think there is a real gap in the literature. And I think partly maybe it's a reluctance on the part of the research community to address that. And I'd also say there's a reluctance for researchers to look at what meaningful engagement means to them. So, you know, we know very little about what researchers feel. So it's a dynamic, you know. A meaningful relationship is a dynamic. It's created through many different people.
Thank you, Claire. I just want to share with you the comment that was posted. It said, "Thank you so much for a truly inspirational presentation, Claire. You've made it so concrete and real for me from a patient perspective. Thank you for sharing your story."
Thank you so much. Thank you. As I said, it's incredibly difficult. I'm normally quite articulate, but this topic, I've been wringing my hands here as I've been presenting, which is not normally me.
Any other questions from online or comments? You want to put them in the chat box? I can read them out. Claire, I'm going to come up with another question, and it's around, because it's become pretty comfortable for me working with you as a patient. And I think part of that comfort was I have worked with you when you were the policymaker, and I worked with you as a graduate student. I still work with you as a graduate student. But are there any sort of little tips or hints that we should be thinking about? Because probably some of the things that I've learned is needing to sort of check in and make sure that you're okay at least once in a while, and not just assuming that if you don't speak up, it means it's okay. Can you comment a little bit around, is there any sort of little hints that we as researchers should be thinking about?
I think the checking in is a big one. I know I would sort of go underground during the particularly bad parts of my treatment and illness. So I think that regular checking in, and actually what I've found is, at work, in the work environment or the academic environment, it's very business-like, and yet I got caught in this in-between space, I think, where it's the personal, sort of that personal connection. It's the relational connection that I valued. I would also say the other thing is, I think one of the other things would be, don't assume that your patients are following what you're saying. Even, as you say, I have experience as a healthcare administrator, as a graduate student and research assistant, but in the acute stages of my illness, and even now where I kind of struggle and take longer to process concepts, I think don't assume that your patients know what you're talking about, and try and, check in with them afterwards as well. That would be my other suggestion.
And one of the other hot points for me, because I've been working with patients on my research teams for a little while, and also have my doctoral students, if it's appropriate, have patients on their teams. But one of the pieces that I've decided personally is to allow patients to be authors on the research studies, because for me, they contributed in the meetings and the discussions. They were present when we sort of designed the study, and they're there at the end when we're talking about what are the implications. And so, but at the same time, when you hand over the manuscript to patients, say, here, read this, so that you can be named as a co-author, there's a little bit of tension there around what's the expectation and what does it take to be a co-author. But I just wonder if you have any inspiring thoughts on this for us, Claire.
Well, I think every patient is different, and I think that it's about checking in with patients who are contributing their experience, any input they have should be acknowledged, but ultimately, as I said, sometimes disclosing an illness. I know that I'm very careful, even in the things that I'm writing, about disclosing too much about my illness. And so I think it really is, again, about checking out what patient preferences are. The need to be careful. The other thing that I would like to talk about is perhaps the elephant in the room, which is, I think a lot of people may not see me as a typical patient, and I don't think there is a thing as such a typical patient. We all bring different things. All of our patients bring different things, whether that's, being a member of a marginalized or group or an ethnic minority, whether that is, holding a position on a board, whether that is someone that is of lower economic earns less than others. I think the thing is to really remember that it's about inclusivity. So I know there's been this discussion around, you know, not targeting the usual suspects, but I think we have to be careful because it's about inclusivity across the board. And I would also say that I'm very much a patient in the acute stage of my illness. And that's why I think as well we need to be including frail and seriously ill patients, because my perspective today as a patient is very different than my perspective when I was halfway through chemo. So I think don't make assumptions about people.
A nice way to end the presentation for today. Megan, do you have any questions that came through directly to you?
I did not, but I wanted to also say just a huge thank you to Claire. I think that's definitely one of the most sort of personal presentations that we had, and I think it's really going to stick with all of the listeners. And thank you, Dawn, as well, for being our moderator today. And I think I haven't gotten any more questions, so I think we can wrap up a minute or two early.
Okay, great. So just a reminder that Megan Story, to email your evaluations to Megan Story or complete the online evaluation. And the next session will be with Jenny Lees from Vancouver. She will be presenting her work on partnering with patients and research through a relational ethics lens. So it's a nice building on today's presentation, and that will occur on April the 11th. So thank you, everyone, for attending the session today, and I'm happy to take any other feedback that you want to send in.
Thank you again.
Thank you.